Okay.
I'll record it and edit it later. So Serdentity is a combination of serene and dentistry, and it's about how to have serenity while you're while you're giving excellent patient care in the dental setting. And something I figured out was that a lot of these patients that present with these uh, very challenging behaviors, they
Oh
present
yeah,
as
you're the queen of you've been the queen of that for a long time.
right. So
Yes.
it's starting to, I've never given up on it. And I'm just doing, trying to do the next right thing to try and get it out there. And so myofunctional therapy showed me that so when I very first met you, I knew that there was a PTSD component, but when I learned about myofunctional therapy and the airway, I'm like, duh, it's the airway.
Isn't it interesting? Back when you and I were talking, I mean, this goes back, what, 20
It's not,
years?
yes, practically 20 years.
You've identified a post-traumatic stress syndrome there, and we're talking about dental patients. We're talking about these patients freaking out, and I'm still trying to think about how to chase little dots on teeth and how to prep crowns better and cement them better and all that kind of panky stuff that I certainly was advocating and teaching at the time. And that we never connected the dots about airway is shameful.
It
It
is.
as a profession. I mean, as a profession, we're working in the mouth, we're thinking about the mouth. We see these patients with all kinds of mechanical challenges to their structure of their maxilla and their mandible, their tongue,
Mm-hmm.
tongue-tied, and it's it's not a big leap to put those things together. And it's like nobody did. Nobody did.
Right. You don't know what you don't know
Yeah, yeah.
until you know it.
So in our defense, a little bit, in 1978, the year I got married to my high school sweetheart.
What?
Yeah, in 1978, the year I got married, was the first year a friend of mine, John Rimmers, who's a pulmonary physiologist. He's an MD. He was up in Calgary, Alberta, and I'm sorry, he was out in Washington State somewhere. And he had a patient that he had put on some sleep machines, and he went around the corner after the patient was supposed to fall asleep, and he's supposed to sit in this little closet and watch the dials and the things go
Mm-hmm.
on. And the patient stops breathing. He comes rushing over, like, what happened? And he did this 3 or 4 times and he wrote the seminal article back then, noticing he called it, instead of obstructive sleep apnea, he called it an occlusion. I love that word, of course, occlusion
Wow.
of the airway. There was
Yes.
sort of occlusion happening in this patient in the airway. It was really one of the first reported communications that was published in 1978 about obstructive sleep apnea as a disease entity. So
Mm-hmm.
I always trip and I say he discovered, uh, he named, if you will, this disease that was existing. It's crazy. And then you fast forward from 78. So give ourselves 78. That's 50 years ago, 45 years
Mm-hmm.
ago. It's taken that long. Now in 2017, the American Dental Association says dentists should be in the airway thinking about sleep-related breathing disorders and screening patients. And the American Academy of Prosthodontists says if you make somebody a bite splint and you open their VOD, it better not be in centric or in centric relation if that patient has an airway issue. So you better check the airway. So there was all these in 2017. That was
Mm-hmm.
7 years ago. And today, still, I just read this the other day in a journal article, and we're talking about 2024 right now, that less than 30% of dentists are routinely screening for airway issues.
Oh.
So this, in our defense, we were earlier than 2007,
Mm-hmm.
2017. We were earlier, but we're still late to the game. We weren't John Rimmers, and we weren't the people that still aren't screening today. So we don't get to pat ourselves on the back. But I think of all those people I made bite splints for in centric relation, and I was closing their airway, and I feel like shit that I was
Oh
closing.
my God. Yes.
Yeah.
Yes. It's iatrogenic harm, and
Mhm.
it's well intentioned with the
Mhm.
knowledge that we had at the time.
Yep, I was protecting their teeth and not thinking about their left leg or their right arm. Oh, by the way, or their airway. I wasn't
Right.
other parts of their body that might have been connected to their teeth and their stomatognathing system. So anyhow, we've gotten off the track already, which
No,
doesn't.
it's wonderful. I love this track. I love everything you've said so far, and it's really great to hear a dental professional say these things.
Well, that's for the last almost 20 years now. Well, since 1991, so that's longer than that. For 30 years, I've been,
That's the year my daughter was born.
oh my God. So yeah, so 30 years, 33 years ago, I started getting invested in sleep teaching with Keith Thornton down at the Pankey Institute.
33 years ago?
Yeah. 33 years ago, I'm teaching with Keith Thornton. We're teaching a TMD course, and he starts talking to me about how these patients always have airway problems. So he was thinking about airway. He was thinking about occlusion and airway and breathing and snoring and all of this and teaching people like me about this in 1991. So I went out and started making some sleep appliances. He taught me how to make a tap, and I did that all back in 1991. And then after a few years of treating some patients sporadically and for cash and all that, I started to feel like maybe I was practicing medicine without a license because we weren't really working well with physicians. There was no great interface. We didn't have all the tools, the knowledge we had now. We were treating patients for their snoring, all that kind of stuff. It was not quite cricket. So I started to fade away from it. And then in 2012, only 12 years ago, I was with a friend, and this friend of me said to me something about my sleep apnea. And I said, I don't have sleep apnea. And he said, you sure do. And so I went home with a sleep test that night, self-tested myself using his sleep test, and found out that I either stopped breathing or had a reduction in airflow 22 times per hour.
Per hour.
Yeah.
Oh my God, 22 times overnight would be bad. 22 times an hour.
Yeah, that's called moderate. Up to 5 times an hour is not
Isn't that
sleep.
crazy? You're
5 to
supposed to be
15.
breathing. Okay. Breathing is good. You're
Yeah.
not supposed to stop.
So not getting enough oxygen. So I made myself an oral appliance. Back then, I made it from a company that makes pink devices, Somnomed. And for somnus, who I worked for 10 years, didn't exist. I went out and got myself some sleep education, went to places like the Pankey Institute, Steve Karstensen. I went to LVI, learned some stuff from the people out there. Kent Smith, incredibly knowledgeable. And off I went on this foray from 2012 on. And in 2014, we got our FDA approval of a device when I was working for and with the team at Microdental Laboratories, which later became Prosomnus, as my lab sold, became Prosomnus. And now I'm on just the educational end. I'm with the International Academy of Sleep. We train dentists how to do the clinical and the business component of sleep, because if you only have the clinical and you don't figure out how to get paid, that doesn't work very well. And if you're in it to make money and you don't really care about treating the sleep, honestly, that doesn't work very well either, because it's not very fulfilling. So this balance of clinical business.
Yeah, it's not ethical either. If
No.
you're in it for the money,
No.
this is so, I've had, so when you came, this was so long ago.
Oh my,
And
Rochester, New York, right?
yes, Rochester, New York. But it's too bad that I didn't have the knowledge that I have, because you already had it. You got that knowledge in 1991. When I was talking to you about PTSD, I had no idea.
No, and so you and I each had a piece of that information, but our heads didn't collide and mesh perfectly. So we never got.
Perfectly, but pretty close though. I mean, because we both knew we were onto something big. And so you were there for some perio study club talking about, and I'll never forget, you had that shirt. You had the shirt. You were talking about selling a shirt, and then you turn around and
it was a great prop.
the
I used
iron marks all
that
over
at a
it.
Sullivan Shine National Sales Meeting with 1,500 people in the room, and I'm standing on a stage with cameras on me, and it worked really well. I got a great laugh out of it. So
Right?
for remembering that, that's awesome.
Oh my God. So, but when I looked around the room, and the doctor that I was working with at the time, they were there because they heard Pankey. If you do go to Pankey, you're going to make a lot of money, and it really freaking pissed me off because I don't remember if you recall this, but you came back to Rochester and there was a very small meeting. It was you, me, and like 2 or 3 other people, and that's when I really came to understand about Dr. Pankey. Okay, he was a deeply spiritual man.
Deeply spiritual, indeed he was.
And he happened to do well financially because of his motive, but his motivations weren't to make a bunch of money.
No, and that's well said. So I think that Harold Worth said it best. He said, if you wear your wallet in your breast pocket, nobody would say breast pocket anymore, but
Right.
But am I allowed to say breast on your podcast?
Yes, you are. Yes, you are.
So if you wear your wallet in your breast pocket, he said, people will have trouble seeing your heart and how you really feel about them.
Right.
So always keep your wallet, he said, in your back pocket. I don't. I carry my wallet in my front pocket.
Well,
metaphorically.
Well, because
Metaphorically,
you and Denise are driving all over the place now, so you can't have your wallet in your back pocket when you're trying to get lower
true.
back pain.
Metaphorically, my wallet's in the back of my mind. I believe that you can do your best stuff for people. And you can do it with people you like, and you can do it for people you like, and you can charge what I would call a fair fee. And when you charge a fair fee and then you get paid a fair fee and you're doing these kinds of things, you can make a lot of money. But the money that you make should be a result of doing the right things with the right people and for the right people, not why you do them. They should be the result of all of that other activity. And that's what Dr. Pankey taught. He said,
Exactly.
he said, we all have a certain capability of how good we can be. And if he were around today, he would be appalled at all of the insurance reimbursement models that dentists struggle with and that live through, because it causes them to continually look around and figure out a way to take cost out. They use a cheaper lab, and they use a triple tray instead of a full arch tray, and they go a little faster with this, and they pay somebody a little less, and they use the spit sucker on both ends so they can get more money. They don't really do that, but
I've never seen that done. Never.
all the kind of things they do to cut costs because their reimbursements are going down. Since 2005, PPOs became the largest type of insurance, and today it's rare to find a true indemnity plan. So practices are challenged to be economically successful. It's another really good result again for a practice to look at getting into dental sleep medicine, because in dental sleep medicine you can, one, do some things that really help patients' quality of lives. People living longer, people getting back together in the bedroom, people's treatments for hypertension, obesity, diabetes, cardiovascular disease getting better. I mean, that feels fantastic. I mean, fixing teeth feels fantastic, but fixing people feels even better. And then the second thing that's kind of cool about it is you and your team will usually feel super fulfilled when you get that kind of feedback. And then, oh, by the way, the insurance companies, which, run the same sort of, reimbursement game as dental companies do, are real insurance. See, dental insurance stops at $1,200 or $1,500, and
Please.
medical insurance usually doesn't even start till there. So when you're billing out a several $1,000 device for a patient, for an oral appliance or a CPAP machine over 3 years and the supplies, or you're doing a $50,000 hypoglossal nerve surgery called Inspire, those things are covered by medical. And so now when I was doing dentistry, you might get 2 or 3 or 4, if you're lucky, $500 an hour of productive productive revenue. Now with sleep, you get 2 or 3 or 4 or sometimes 5 times that. So it feels good to help people, feels good on your own heart and your team's heart. And oh, by the way, you get paid a lot better than you do in dentistry. So a lot of people are adding dental sleep medicine to their practices. They're taking training, with us, IOS and places like that, or Pankey or at the AEDSM, and they're learning dental sleep medicine, and they're treating some of their own patients. They're screening their own patients. That's the other thing. They're more likely to screen the patients, which they should do. If the end of that rainbow is a little, treat for them in terms of making a few bucks doing something. There's nothing wrong with getting paid. There's nothing wrong with being profitable, but
And
as a result of.
you know what? That's a problem I have. So when I was trying to work on my own as an orofacial myofunctional therapist, although New York has done a great job of putting the kibosh on that, but this idea that it's okay to get paid, that it's I feel guilty, right, asking for money, and so I'm not seeing live clients anymore in New York. I work for Shirley Gutkowski in Primal Air, and I see all my clients virtually. And I've seen people from all over the country for orofacial myofunctional therapy. And it's just more comfortable for me to work in that sort of a situation where I'm not having to do that part. But I know I could have done better. And I find myself a lot of times, giving away where, these influencers are always talking about value. And I don't know if it's that I don't value myself, probably a little bit, but, this idea that there's something wrong with getting, money. There's something inherently evil about money, which is that's not true.
No. I think if you are making money for the sake of making money and you want to hoard it, and there's this question of how much is enough, and we could get deeply philosophical in that whole arena. That's different than saying, I have a skill set that I can help people with.
Hmm.
And if I execute on utilizing that skill set to help people get healthier, that the system that surrounds that activity reimburses me in a way that puts me in, the upper 10 or 15 or 20% of the income earners.
Hmm.
And and if I never gave to charity, if I didn't tithe, if I didn't occasionally do a case and not expect to get paid for somebody that couldn't afford it, if I never gave back and I was doing really well, I would say shame on me.
Hmm.
But I can probably give away more and do more from a position of somewhat prosperity, some level of prosperity, than I can if I'm struggling to pay my bills as well.
Yeah.
And so the other coin for you is to say, the other side of the coin is for you to say, if you're going to do oral myofunctional therapy and you don't care about getting paid, you're not going to do very much of it, because you're going to have
Isn't
a way to make a living and pay your
it?
bill.
Yeah, it's like a mindset.
But
Um,
if you can find a way that, hey, this is my income, this is my livelihood, and I can support myself and my family in the style that I want, then I'll do more of this oral functional myofunctional therapy, and I'll be successful at it. So it's
well, Rochester, New York has been amazingly slow. And I got my education in 2018 and I hit the streets. And I just really had a hard time. I went to all these offices talking to these doctors, and they all agreed that it was a good thing, but I never got referrals from anybody.
mm-hmm.
So there's I think there's four. It was only me for a couple years. Then there was I think there's four myofunctional therapists in Rochester now, and they all have the same. We all have the same complaint, which is how do we get these doctors to value this therapy?
It's a challenge. So I live in so although I've lectured at the AAPMD at Collaboration Cures, where there's a lot more of what you're talking about, and everything from frenectomies in newborn
Mm-hmm.
to full myofunctional therapy, breathing techniques. I mean, the amount of knowledge that we have.
Mm-hmm.
Um, Yet I don't live in that. I've lectured in that world, but I
Mm-hmm.
don't world because I've kept a very narrow focus on adult rather than child. Even though I know
Mm-hmm.
very much more preventable. My granddaughter, when she was 5, we put her into rapid palatal expansion with a friend of mine and
Mm-hmm.
expanded her maxilla and her mandible. And guess what? She stopped snoring. Guess what? She did better. My grandson from my other children went through a time where he was having a problem with wetting the bed after he'd been
Yes.
trained, and we
Yep.
got his sponsors and adenoids out. And guess what? That went away. So, I mean, I'm fully aware of how we can prevent so many of these problems, but I'm still buried under trying to train enough dentists to
Mm-hmm.
treat obstructive sleep apnea in adults. That I'm not discounting. I'm not saying that we shouldn't. I'm just saying that. And then all of these other things. So if you're a dentist and you're making your living all day long with a handpiece in your hand and a syringe, finding the time to even step into the 70% that aren't screening for adults for obstructive sleep apnea, let alone looking at kids, looking at oral
Oh, right. Right.
myotherapy, and oh my gosh. So, breastfeeding. I mean, we could go on and on with.
Mm-hmm.
So until we get this kind of core of the problem managed, which is, 40 or 50 million Americans, till we start to get that core of the problem managed better, it's going to be very difficult for us to focus on the kind of things that you can do or others
Mm-hmm.
can in some of these other arenas that are so supportive and so important. But it'll take a while. It might, it took from 1978 to the last 10 or 12 years for us to get well versed, and we're pretty smart people to get well
Mm-hmm.
versed looking at airway, and we're still slowly grading through the dental population to screen. Think about how long it took to get perio to the
Mm-hmm.
forefront of dentistry. I mean, the American Academy of Periodontology came out with that, what was it called? SRP scaling and rating, where you
Mm-hmm.
went 6 spots. They didn't
Right.
come out of that because everybody was using a perio probe. They came out of that because nobody was using a
Nobody
perio.
was using a perio
And that
probe.
was a way to get you, well, if you could just use the superior probe in 6 spots, and if that set off an alarm bell, then you got to probe the whole mouth. We'll let
Mhm.
you do that. And so think of how many years perio rode on the back of the bus, so to
Mhm.
speak. And so airway is still on the back of the bus.
Yes, it is.
We have 200,000 dentists in this country, maybe 150,000 actively practicing GPs.
Mhm.
And when I was at Prosomnus, our estimates were we probably have about 5 or 6, maybe 7, I don't think so, thousand dentists doing anything with sleep.
Wow.
And maybe 5 or 600, not 700, but maybe 5 or 600, and maybe even a little bit less, that are doing a lot of sleep. Now, if you had just say 1,000 dentists doing sleep, a lot of sleep, out of 200,000, that'd be 1/2 of 1%. That's crazy.
Yeah.
And if you say 5 or 6,000, if you say 6,000 of 150 practicing GPs, 150,000, that's 4%. So when you put into perspective that there are very, very few dentists actually treating sleep,
Mhm.
okay? There are actually very few physicians treating sleep, by the way, too, because
Right.
it's an undervalued specialty. They're paid poorly. They can't fill all of the residencies on match day anymore
Huh.
that are sleep. Sorry, my Alexa's talking in the background. They can't fill those residencies because the pulmonologists, the neurologists that go into those don't find themselves able to make much money from that residency program. So
Hmm.
they're finding other places that they put their time, effort, and energy because, like you and I were talking, they have to be able to pay their bills with what they do. So you'll see a pulmonologist who's an allergist and sleep, a pulmonologist who's
Mhm.
a neurologist and sleep, or a neurologist who, you'll see these multiple specialties. But there's about uh, pulmonologists, maybe about 4,000 pulmonologists that are board in sleep. There's maybe about 1,500 neurologists that are board in sleep. That's 5,500. And then there's about 500 either ENT, psychologists, family practitioners, cardiologists, spread across all those other specialties, because most of the specialists who are in sleep are pulmonologists or neurologists.
Mhm.
There's only, think about that, there's only 6,000 of them. So
Right.
there's a real shortage of attention and medical structure for healthcare delivery in and around sleep. And that's why dentists, we could really play an important role, because today with precision oral appliances, I was with Prosomnus for 10 years, but you'll hear me say precision because I
Mhm.
kind of dropped that word out for Prosomnus, but precision oral appliances work about 20 or 26 percentage points of efficacy better than traditional appliances. They have better adherence, they have better effectiveness. They're in trials right now to get clearance for precision oral appliances as a first line treatment, even for severe.
Mhm.
One insurance company, United Healthcare, will only pay for your hypoglossal nerve stimulation surgery, which only works 68% of the time, by the way. That's the efficacy data. And
Yeah.
they turn it on 7 times out of 10. They'll only pay for that if you fail CPAP and an oral appliance. So you're going to see oral appliances move more and more to the forefront. It's an inexpensive, cost-effective way for healthcare to deal with the ravages of sleep apnea. No question about that.
Well, so I'm a classic. I have a CPAP. I had extraction retraction orthodontics, so my palate was too small to begin with, and they made it smaller.
Yeah.
So,
But they made your teeth beautiful. You got that
oh,
going
that's
for
right. I have a pretty smile. And on my CBCT, you can see my tongue, even though it's fully engaged in the palate, protruding into the airway.
you.
So I
100%.
have a skull problem,
Hmm.
and it's
You have a full-size car in a tiny garage.
exactly. Have you heard of or read any of Dr. Felix Liao's? He wrote a 6 foot tiger, 3 foot cage was the
There
book
you
he
go.
wrote, and he talks about impaired mouth syndrome. So he's a dentist in
Yeah,
Virginia, and he's really connecting the dots. And
yeah.
his primary focus is, you know, uh, treating the impaired mouth syndrome.
Bill Hong, Barry Raphael, all those people, they do such a
Yes.
good job with growth. I wish we could grow adults without surgery. I think Vivos would
Can't.
be a more attractive nuisance if they could more successfully grow the maxilla in adults. But really, if you think about it, if we wanted to grow your maxilla today, and we did SARP, surgically
Right.
assisted rapid
Hmm.
palate, we did SARP and grow your maxilla, we could still kind of grow you, surgically grow you without maybe an MMA or something, mandibular maxillary advance, we could maybe still grow you to some extent out of some of that problem. But it's a bit more of an undertaking than saying slap a CPAP on.
Oh my God. Yeah. Yeah.
And that's a little bit easier.
See, and CPAPs are, although, come on, that's like the gold standard. Are you kidding me? Like a wind tunnel up your nose. That's what they came up with. But
My good friend from Syracuse, New York, Eddie Saul, he's an ENT who's boarded in sleep. Good friend of mine. I've taught with him for a long time, and we were at Prasanas together. Calls it the gold plated standard because it's about how gold that standard is.
right.
When 50% of the people won't use it at the end of a year,
Right.
that's a problem. It's a great therapy if you can tolerate it. And for my patients that I would see, for sleep, if they were open to a CPAP or they had a family member that was successful with CPAP and that became a model for them, there's nothing wrong with CPAP. But I like to go down a path where I know I'm going to have 90 or 95% success with adherence.
Mm-hmm.
Something that they'll actually use. Maybe try that first, and if they fail that, then you have a stronger discussion point to make about why they have to use CPAP. So
and so last night I was sleeping and I turned over and the CPAP fell off the dresser and it fell on the floor and the front popped off. Whoops. So, there's those limitations too. But
have you tried like combination? If you get along well with CPAP, you don't have to do anything. But have you tried combination therapy?
what's with like a CPAP and a mouth?
So CPAP and an oral appliance. So in patients who struggle with the CPAP, like for example, if they get a lot of air leaks, if the
Mhm.
pressure is high and they feel like they have trouble exhaling into that flow of air,
Mm-hmm.
wearing an oral appliance, even if it's not fully successful for them, at least opens the airway a little bit and usually allows the pressure to be lowered. So we've seen people with 14, 15 pressure settings drop down to 6, 7, 8.
Mm-hmm.
And that lower pressure usually is a much more tolerable adherence for that patient, compliance for that patient wearing
Mm-hmm.
it. So sometimes that's a solution. The other thing that we fail to think about is when we say combination therapy, we just mean two different therapies or multiple therapies. And so for you or me, if I'm wearing an oral appliance, I know that my oral appliance will be better when I'm on my side than if I'm on my back.
Mm-hmm.
It's true with your CPAP. Your CPAP will have an easier time if you're on your side than if you're on your back. And so anything we can do to add to the efficacy and the adherence of whatever the treatment modality is, it's like if you've had to take a medication and it really upset your stomach so much so that you'd throw up, you couldn't,
Mm-hmm.
you'd say, well, we have an adherence problem with that. But if you found out that if you took it in combination with something else, it would settle your stomach and you could keep it down, then
Mm-hmm.
that combination of therapies might make that one more effective.
Yeah. So I was thinking, so mouth breathing. I mean, part of the reason that people can't tolerate a CPAP is that they are mouth breathers. So if you put this over their nose, modern humans don't know how to breathe with their nose. And that's when you're over at the AAPMD and,
Yep.
there's Buteyko and all this other stuff. People
Yeah.
have to be taught how to breathe
Yeah.
with their nose.
That's why taping's become, I tape every night, but that's why
Mhm.
tape becomes so popular. I think of my oral appliance as part of my treatment. Now for me, honestly, the motivation for me to tape was more about I hated waking up with a dry mouth because I knew I would
Mhm.
mouth breathing.
Mhm.
I would do some mouth breathing in a more protruded and an
Yep.
open air position. High five, my numbers would come down from 22 to 6 or 7, and I could live with that. Well, if I tape and breathe just through my nose, I oxygenate better. My oxygen levels are higher. I get a little bit more deep and I get a little bit more REM sleep. I don't wake up as often per hour. I don't have as many arousals. So I know that the taping and good nasal breathing, not to mention nitric oxide production, et
Yep.
cetera, et cetera. So I've got all these advantages. But I'll mention taping to patients sometimes, and they'll go, "Tape? You tape your mouth while you're
Mhm.
sleeping?" Well, yeah. I go, "It's kind of weird, isn't it?" They go, "Yeah, I don't think I could do that." I go,
Well,
"Totally."
won't I die? I'm like, you're not going to die. Okay.
Yeah.
Your
And,
body's not going to let you die.
and really that tape has got a tiny bit of breathability through it that we use. We use that Medipore tape, 3M Medipore. Uh,
Hmm.
got
Uh,
that,
there's myotape too that goes, it actually leaves an opening for the mouth. I just
yeah.
use like a little piece of medical tape.
Yeah. The 3M Medipore tape is really, really effective. It's good and sticky. It even works for some people that have some facial hair like I do today because I haven't shaved in a couple of days. So
So these patients that, they're presenting with airway issues. These are the same patients that also can present with very negative behaviors. And it comes back to the same thing.
Well,
They
if you
can't breathe.
if you think about something as simple as a defensive mechanism to protect yourself, we all have three brains. We have an amphibian brain, an amphibian reptilian sort of brain, and then
Hmm.
outside of that we have this what we might call a mammalian brain,
Yep,
where where we have our feelings. So we have these reflex actions. When you tap the patellar ligament, the leg kicks out.
yep,
You
yep.
don't feel that. You kick out before you feel that. That reflex arc happens at the level of the spinal cord and goes right back out. And then other afferent neurons take it up to your skull and tell you that that happened. And then you have this thinking brain, and then finally feeling brain, and then outside that you have your cerebral cortex, which is our Homo sapiens, thinking man, thinking woman, and we've got these capabilities. Well, the protective mechanisms from that reptilian brain that we have are super important, because if you touch something and it's hot and you pull away, you learn to not touch that object because it's hot, and your body wants to protect you from that. And so these reflexes, and they can be quite strong. If your airway is compromised, you're going to protect that airway.
Exactly.
And so,
Exactly.
and this goes back to our seminal discussion, 20 years ago in Rochester. So now, if I put my fingers in your mouth and you have a really strong gag reflex, is the gag reflex because you've got way too many neurons in your tongue? Or no, it's probably because your airway's compromised.
Exactly. You're
With
protecting your
compromised
air.
airway, you're protecting this place where, I'm even a little afraid to eat and chew. And how you eat and chew your food is probably different than I do, because if somebody's got a gag reflex and they've got a compromised airway, they're going to be very careful with how they move things around in there, because they've had some incidents, and those reflex arcs are strong. We see patients who we treat them with an oral appliance, and I can barely take impressions. I can
Oh,
barely
right.
get the oral appliance in. And then 3 weeks later, I could give them a full coverage lower appliance, and they can tolerate it because their sensitivity with that gag reflex has dropped down dramatically. Steve Carstensen actually warned me this was going to happen. When you see a gagger, he says, they might not stay a gagger for very long when you treat their airway, because once they feel confident that they don't have to worry about their airway all the time, that sensitivity to that reflex goes away. Much like if you have a child, we're talking
Hmm.
how old our children are. Mine are 43 and 40. So how old our children are. When the children are little and you're in the room next door, you hear every little sound. And the tiniest little sound wakes you up because your arousal threshold
Hmm.
heightened, your awareness is heightened, listening for the baby to cry. That goes away, of course. So your senses and your sensitivity to outside stimuli that would awaken you, arouse you,
Hmm.
that can change. And the same is
Hmm.
true with the sensitivity to a gag reflex.
I love when you're talking too about the triune brain. So,
Iron Brain, great name, great name.
trauma, affects our executive function. So somebody comes into the dental office and they're in a full fight or flight mode. And we lay out, we get them in the chair and we lay out this huge treatment plan, and we're wondering why can't what I put it on
All
nice
they're thinking about is,
paper.
how the hell do I get out of here? How the hell do I get
Right,
out?
right. Just because I put it in a fancy bolt, binder or whatever, that's freaking leather or some shit,
So
it
true.
doesn't matter. So
So true.
this is what I'm trying to get across to my fellow dental professionals, is that these patients that you're ranting about in Facebook groups, there's a reason that they are
Mhm.
acting this way.
Yeah. It's a challenge. I lecture 8 or 10, 12, maybe 15 times some years, teaching sleep, dental sleep medicine, dental sleep education to dentists. Most of the time, I'm teaching what I would call newbies, people that are just getting
Mm-hmm.
it. And so I can kind of guide them along a path, but sometimes when I'm teaching, these dentists have already been trained somewhere else, and sometimes it requires a little untraining to get them retrained. And one of the hardest things for us to figure out about learning and our own learning is unlearning what we knew before, so that we
Mm-hmm.
can learn something new. And so, I've had these conversations that the Pankey Institute is a great place, but there was a time when I had a conversation talking about the uh, P prosthodontic paper, where they were saying that if you're going to treat somebody with a bite guard, you should think about their airway. And
Mm-hmm.
this person was so automatic in their responses about centric relation and bite relationships and chasing dots, that they couldn't hear me because they couldn't unlearn or look in the mirror and say, I may have made some people sleep worse with
Mm-hmm.
the devices I was making, even though I was using state-of-the-art technology, thinking, and everything at the time in dentistry. We just hadn't thought about these other components. And the ability to unlearn and relearn something new is a challenge for dentists, is a challenge for human beings, is a
Yes,
challenge.
it's for
Yeah,
everybody.
it's in life.
So in the Pankey philosophy, where you're sort of trying to meet patients where they're at,
Mhm.
how do you work with patients who, because of their airway, they're refusing x-rays? And you come and I come at them with, well, blah blah blah, all the science or legalistic terms, and they're not having it. What do you do with that?
I think the answer to that should be highly personal between the caregiver and the care receiver, and the two parties, the caregiver and the receiver, can sometimes almost change roles in a good relationship where we're
Mm-hmm.
trying to drive for mutual health. You want the health for the patient, and you want health for the doctor and the caregiver as well. And sometimes you need information, and that information that you need might be provided by a radiograph. And you need information to be able to make good healthcare decisions on that patient's behalf.
Mm-hmm.
But I remember what Steve Ratcliffe said to me one time when I was talking about patients that didn't want to accept treatment. And he asked me, have you ever been on like a mission trip or one of those kinds of things? And I said, yeah, sure. I've done that. I volunteered at a inner city clinic in Detroit. He said, what kind of dentistry did you do there? Did you do centric relation, occlusal rehabilitation, an implant? No, no. What'd you do? Well, I ripped out teeth and made dentures, man. That's what we did. Those people were in pain. Those people couldn't work. Those people couldn't function. And
Mm-hmm.
if you do it, and I have never been to another country to do that. I've done it here in Detroit.
You
Um,
don't need to go outside the US. There's plenty
yeah,
of
man, but it would have been fun to do in another country too. That would have been great. But when you go there, if this person walked into you and you wanted X-rays and you wanted mounted study casts and you wanted all this stuff and impressions and everything, so that you can make a good diagnosis and treatment plan for them, but that person's in pain and can't go to work, and if they can't go to work, they can't feed their family in the
mm-hmm.
field. Then the appropriate treatment for them, comprehensive appropriate treatment for that patient, if we personalize it, might be extracting those teeth and making them a denture.
Mm-hmm.
I'd say the same thing about radiographs. If I had a patient in front of me and I felt like I really need more information to be able to render the kind of diagnosis you need, then that patient and I working together could come to the conclusion that I'm not going to have that today.
Mm-hmm.
And we could accept together that we'll do the best we can with the tools we have available to us because of the compromise we have in information. Or that might persuade the person to try to thunder through trying to get those bite wings taken or that
Mm-hmm.
radiation taken. It's not a perfect world. I wanted it to be a perfect world. I wanted to equilibrate everybody. I wanted to treat everybody like this perfect panky patient when I was first going through my idealistic boat
Mm-hmm.
training, and that's not the real world. The young man that bought my practice from me and took over has also been panky trained, and he is so much more inviting, so much more inclusive in terms of how he thinks
Mm-hmm.
about patient care than I certainly was, even at the time I brought him on. He was a great breath of fresh air for me to unlearn that I should always do my best,
Mm-hmm.
even if my best wasn't the right thing for the patient. That's how I
Mm-hmm.
feel like it. I would have said to a patient 30 years ago, I would have said, well, if you won't let me take x-rays, honestly, I can't treat you.
Yeah.
Go somewhere else.
Well, and that seems to be the solution in these different dental groups that I'm reading about. And people are talking about supervised neglect, liticophobia, right? You're going to get
Yeah,
sued.
what's trichophobia?
Liticophobia is the excessive fear of litigation. How do you like
Well,
that?
love it. I love
That
it.
English degree is not going to waste.
That and serdentity. I tell you, you got all kinds of new words going on.
But whenever I read these professionals, and my heart breaks for them because I know that they are so frustrated, and
Hmm.
it's not a fun, good way to go to work. And, but I always want to, but sometimes when I've, replied along the lines of what you and I are talking about, "Whoa, no, no," or, include a scenario where, a patient came in today and, um, you know, the appointment went this way, and was it a perfect appointment? No, but that person left feeling like I had cared for them rather than beat them up. And
Mhm.
oh my, the outrage that, I didn't, yeah, how can you blah blah blah. And I don't know, I guess I'm naive, or I don't know.
Idealistic, not naive.
Yeah, idealistic.
I remember on many occasions where my hygienist would tell me, Linda would come in and say to me, Mark, I just finished with Mrs. Jones, and you don't really need to check her today because we didn't really get a chance to do much of anything in terms of cleaning her teeth because she came in with some issues and some problems, and we talked through that and we
Mm-hmm.
little things for her, but you wouldn't call it a full cleaning. She's going to come back. I'm going to reschedule over another block of time, and we'll do some more of the cleaning stuff for her and everything like that. But that's what that patient needed that day. Now, I was in an office where I wasn't participating with an insurance company, so I could charge that patient for 2 visits. So there was no economic penalty for me
Mm-hmm.
treating that patient and or my hygienist making the decision to treat that patient like a person, a
Mm-hmm.
procedure. And so if she needed more time, she could have her back. And if this time was we cried together about something for an hour, that might have been the best thing that Linda could do for Mrs. Jones that day. We'll have her back and scrape the shit off her teeth another time. It doesn't have to be today in this 60-minute appointment. And so,
Mm-hmm.
but not every practice can do that because
Yeah.
they're challenged with how they make their decisions. That's one of the things that I think is interesting about when a dentist starts to do a little bit of dental sleep medicine in their practice. A lot of them want to do more dental sleep medicine and less of the dentistry
Yep.
because they get paid more for thinking, they get paid more for caring. It isn't so much about the procedures getting paid for. I mean, there is a couple pieces of plastic you stick in somebody's mouth, and there's a code EO486, and that gets billed out to insurance companies. But the reimbursement is enough that if I spend a little bit more time with this patient, a little less with this one, I don't have to whine and cry. I don't have to always take cost out. I don't have to, you know, regiment how I'm going to treat everybody the same. And so I think that's one of the attractive things about sleep. The other thing is, this idea of what we're supposed to do for patients or doing my best stuff. I mean, hell, I know what a complete and thorough exam is. I mean, we learned that at Pankey, and the
Right.
kind of exams I did as a dentist for my dental patients is very different than the kind of exam I would do to determine whether or not a sleep patient referred to me by a physician with a prescription for a fitting of an oral appliance.
Mm-hmm.
I really just need to determine, can that patient or can't that patient wear an oral appliance? Do they have enough teeth? Are they healthy enough? Um, are their joints, their muscles capable of managing being forward for 8 hours at night and then rebounding in the morning? It's not the same kind of dental exam. It's not the same kind of I don't feel I have
Mm-hmm.
requirements for radiographic information or imaging information or periodontal probing information. And so, it's hard sometimes to step away from dental thinking in the
Mm-hmm.
world and think this airway is a hell of a lot more important than a perfect bite. This airway is a hell of a lot important than getting that tooth fixed. This airway is a hell of a lot, but it is.
It
And
is.
that's a hard challenge for us to make. That's for sure. Hard change.
Well,
Hard
and
thing to unlearn. We're back to that unlearning thing.
um, have you ever heard the set aside prayer?
I have not. I'm a fond believer in the Serenity Prayer, which sounds like your shirt, but not the set
Yes,
aside
yes.
prayer.
Serdentity
Share
is
it with me.
based on the serenity prayer. The set aside prayer goes, "Dear God, help me set aside everything I think I know about blank for a new experience with blank."
Ooh, I'm going to use that next time I lecture. And here's what happens. I'm going to give you credit. I'm going to say, Beth, my good friend Beth, always said. And then after a year, I'm going to say, an old friend of mine used to say.
An
And
old
then
friend of mine.
the third year I'm using it, I'm going to say, I've always said.
Right, right. Like I always say.
I'm going to set aside everything I know about this so I can have an open mind to learn something about this.
Yeah,
Which might be
because
the same thing. Which might be the same thing, by the way.
it's it's what I think I know that's the problem. That because my mind is closed.
Well, think of, when you see those charts with the different types of of conformational biases we can have about things. You know, I've seen some symbol charts with 8 or 10, but I've seen some with like 30 and 40 different kinds of biases we can have.
Mhm.
And several books on that. And I've learned so many lessons from my kids about not judging people and
Mhm.
some of these biases. And yet every single day I can sign a couple of times when I've still had some confirmational bias, watching something on TV or seeing something happening in my life. And I don't intend to. They're not conscious confirmation
Right,
biases.
right. But,
Yeah.
all we can do is keep an open mind.
Yeah. It's
So,
a we're covering a lot of topics that make for a good caregiver psychology or socio psychobabblology or whatever you want
Babylology. Well,
to. We need this to be better than like this, when we're
mhm.
doing dentistry or hygiene, you know.
Well, you and I figured it out. So how hard can it be? Right?
Yeah,
There,
good point. If I
we
can figure
just
it out, I'm figuring out most people can too.
right. We just got to keep talking about it. And the more you treat these airway people, the less dental disease they're going to have
I agree
because
with
that the airway is what keeps the mouth healthy.
that. Yeah. Yeah, I think that's true. I think I mean, we'd still have dental disease to treat, but man, we would have less of it and we'd have less cardiovascular disease and we'd have less diabetes and stroke.
Mhm.
We could go on and I'm particularly sensitive to this. I'm 68 this year. And I'm going to tell you, when you get up in the morning and you're 68, you look at the day a little differently than you did when you were 58 or 48 or 38 or
Right.
28.
Yeah.
And no matter how much you want to think about your youthful vitality or your good young thinking or whatever, know that the road in front of you is a hell of a lot shorter than the road behind you. And you
Hmm.
start to get very careful with how you say yes to things and say no to other things. I said yes to doing this podcast with you when you reached out because it's you, and I know how passionate you are about things. And I'm thinking, well, this will be an hour of my time. I'll enjoy talking to you. I always do. We'll enjoy talking about these kinds of things. I always do. I'll come away from it feeling good, feeling fresh, and I already do. And
Yep.
so it'll be good. It'll be good food for me, my heart, my head, and good food for you. And hopefully
Absolutely.
someone will listen, and maybe it'll be good food for them if they can use that set aside prayer and set aside something and open themselves up to something else. But 68, it comes fast. And kids 43 and 40, it comes fast. It comes really fast.
Yeah, I'm 62 this year, so I can get Social Security. Woohoo!
Yeah, I'd wait till you're full retirement age, but that's a whole nother financial
Right,
discussion.
right. We'll talk about that another time. So, um, I can't even tell you how much I have loved this conversation.
It's fun.
It went exactly as I hoped, and
And so carefully scripted out. We carefully scripted this for
that
hours
that's
upon
right.
hours
That's right.
upon hours.
Yeah, I really made you
You read
said,
my
look.
scripts right here, everything like that. Zero.
So, thank you again, and I don't think I'm not even going to edit this. I'm just gonna
So roll with it. So
I'm
Beth, if anyone wants to get a hold of me, they're welcome to email me, Mark
mhm.
at IAOS.com, International Academy of Sleep, IAOS.com. They want to talk about airway, want to learn more about sleep and sleep medicine. Happy to do that. Happy to answer any questions. Sometimes it takes me a day or two to get back to somebody because I used to say because I was so busy. Now it's because I try to block my time when I'm working and block my time when I'm not working.
Right.
This last weekend, 2 days, 2 full days, I did not come downstairs and touch my MacBook Air once.
Good for you. That's what we got to do that. We have to learn how to.
Have to do that. Yeah, I got to find time for us.
Yep. So I'm God bless you, and it was really
Hey,
great talking to you. And we'll see each other when we see each other.
appreciate your breath. Thanks so much.
Okay.